we are taking a help of AI, which takes into the consideration of symptoms, vitals, as well as the ECG reading, and then gives a prediction to the doctor, to the healthcare provider, that who is little confused, that he get more like confident that okay, this is this type, and then has a system to connect to the expert. Like okay, now we have take to the expert. So we are in a developing stage. Now we have only gone through a proof of concept where we have seen the system where the ECG is analyzed by the AI tool, which is telling the percentage of chance, and we have not yet fully reached to that level. Our journey is going. As Dr. Santosh was telling, when we are trying to do this, so many ethical dilemmas and other things are coming, but we are now taking, as we are from modern medicine, we are going through our own ethical committees and other things where everybody is having, the peer group is looking what we are trying to do, and if it comes to everybody's acceptability, only then it will go. So right now it is only, as Dr. Santosh rightly said, it is only for the doctors to reinforce their capability with the AI tool. So,
sir, just as a part of curiosity, how far, I mean, as per your clinical experience, how far this AI really assesses things properly?
Sir, take it from me, sir, it is going to come in a big way. Either you accept it or you don't accept it, it is going to come in a big way in very short period of time. People who are non-medical field, they are adopting very fast, and someday or other the doctors also will be forced to adopt it. So now the fraternity has to think and utilize it in a way where the patient benefit is the core, because we understand what the patient needs. The AI tools which are developed are mostly developed by non-medical people who do not handle the patient, they develop it. But when they develop their perspective, as we are talking about the corporate hospital, doctors not running the hospitals, their perspective is different. Here, if we are trying to part of this journey, as we are doing with IIT Village, they have their way of technology and we have our way of patient-centric care. So now we are trying to see what can be the best way to do it. So for everybody, I will just advise that this is where it is coming, this is where we have to put our mind, see how to use it in a right, ethical way.
Sir, is it possible? Is it possible to get a Uberization of referral systems? Therefore, that this point was just raised that if I should be able to refer down to somebody, there's no point in my wasting time on a hernia or a hydrocele. Can I identify somebody in Bihar who's good at hernia hydrocele and say, "आप इतनी दूर क्यों आता है? वहीं पे करा लो." Can those systems be set up by AI? That you know which is the PHC in your area, you know which is the CHC in your area, you know who the doctors are there, and you can say, why don't you go to ABC doctor and just get treated because he's competent or she's competent.
Exactly, madam. If you have a mapping of doctors and services provided in a central place, you can, and availability, like as I was talking about the emergency care, trauma care, where we know that if I refer EDH, which treated, now further care has to be done. But I should know that where somebody should be able to take. If there is somebody there, but they don't have a bed, now if I refer the patient there, again it is futile. So we have to have a mapping, and AI should be able to automatically guide the patient where to go. Like many many countries are there, ambulance itself, they have a system where the patient will reach the caregiver in the shortest period of time. That has to technology driven. The older days of calling to a call center, the call center finding it out now. Now everything can be automatically done by a tool.
That would require a lot of standardization of care, and also bit of a star rating, kind of the way you rate the Uber drivers and the way you bring Ubers. The same, there will be some rating systems and standardization both.
So really important points you said about standardization, SOPs, they need to be created. Sir, Dr. Arun, sir, please.
Basically about, AI, I think there are two things which I would like to point out. One is not just AI. I have noticed that say in West, medicine is driven a lot by guidelines. Like guidelines are there and the doctors generally are expected to follow guidelines. They are implemented by the management. In India, we have a very limited usage of guidelines. Everybody sort of runs in a very autonomous manner. So somehow to have a standardized system of guidelines available, which are also having a framework to support that if you follow those guidelines, you are doing right by the patient, because these issues often come when there are sort of adverse outcomes, medical legal issues come, so there is nothing supporting the treating doctor in the form of any endorsed guidelines. So same thing would come when we have AI-based decision tree systems, and also we need to have a enabling legal, and not only legal, maybe our own professional bodies also have to endorse that okay, these systems are right systems to use. And secondly, I believe that AI is definitely it's the tool to go for, but we find that whatever is the training data becomes very critical. So if the training data comes from Europe or it comes from America, so if we are talking of AI for India, we have to have training data for India. It should not be that for commercial interest a model which has been developed in US or Europe is forced upon us.
Very, very important point, sir.
MIT will come into
Sir,
play also. With more data.
I'd like to add.
Sure. Please go ahead, ma'am.
Yeah, so AI, like you said, it is going to come in a big way today or tomorrow, because that is the future. But that one thing we must understand, that it develops in cycles. Like first we have to develop, we should have the proper database which is suitable to our country, and documentation will come in a big way. Then once some kind of models based on protocols and all, once that is developed, that is the second stage. Third stage is the testing part of it, which can happen. India, so many places which can, and finally adopting it. So what we face right now, so it is not going to happen overnight, but certain things can happen, like having it is already happening. I think radiology and all, diagnostics and all are happening through AI. So many things can be done, and reference, as you told, that reference system can be fed into it. These are not very risky things, low hanging, but the decision part of it, So fragmented data, if you don't have proper data, fragmented, because clinicians have their data, technologists who will actually develop it, they are fragmented. Then data is with someone else. So all these pieces have to come together, and then only a proper sort of
data yoga is perhaps Madam is surmising at, because
Absolutely, data yoga is the word. We joined by Dr. Vipul Nanda, sir. He is a cosmetic and plastic surgeon with Artemis Hospitals and an AIMS in Zonian. So I would also welcome Dr. Vipul Nanda, sir, to the forum. Sir would like to speak a few words.
I just add the AI thing, just a humbling thought. In fact, there was a study in which an AI-based chat box was used to consult. I mean, they compared 3 plastic surgeons or rhinoplasty surgeons and a chat box based on AI, and they found the AI chat box answers were comprehensive, more complete, and most of all, more empathetic. Can you beat that?
My goodness.
More empathetic than the human.
Sir.
If may I?
Sure.
Yeah.
Shobhit Kumar, sir, from Niti Aayog would like to speak.
As sir was mentioning about, so
Sir.
Gujarat has done a pilot regarding this, AI modulated emergency system. So they have mapped all their facilities, and whenever any emergency occurs at the primary care level, so then it is reported to the nearby health center that you are going to receive this patient, so that they are also prepared to receive that patient. And if they are not, if somebody is on leave, though they have inbuilt system who is available, even though if they are not in a capacity to receive that patient, then they immediately inform that you should go to the nearby other facilities. But when we talk about use of AI, as sir was also mentioning, reducing load on tertiary care facilities. So if we see isolated AI development, is not going to work because we need to develop a whole ecosystem. If we talk about, see, in primary care or secondary care level, if we are using teleconsultation, and in teleconsultation, if certain, diagnostics and medicines are advised by the, say, specialist or doctor, but if it is not available at the primary care level, then its purpose is not going to solve. Or if we are, referring patient from tertiary care to secondary care or lower level, if similar, medications are not available or the person is not trained to adjust the doses and also this is not going to solve the issue. And so we have to see this holistically, and definitely government is taking measures regarding this, because if we see the data of CSC and district hospital, there are more than 60-70% shortfall of specialists in these facilities. So one is of course quality of care. So for that government is encouraging, NQAS and other things, and other then that is availability of doctor. Definitely, as we all of us are aware now, medical seats have increased drastically, and also the number of specialist seats from 30,000 in 2014 to now we are having around 70,000 seats. So definitely in coming time it will improve availability of specialists and modern doctors in rural settings also. But when we talk about the use of AI, then we have to see things holistically. Skilling of our HR, development of AI tools, and building other the other building block of health system in place. Then only this AI will work. Yeah.
So the basic crust of all these things, if all the experts are there, and so I would just say that if we have a proper database of all the 130 crore people we have, then probably it will be very easy for the AI to analyze or tell us about the data as well as the patients.
So I think basically the data, it is not only pure sort of basic epidemiological data, we have to go for the medical data. Now unfortunately, as on date, the medical data we have available is sort of in analog form in their prescriptions. So first point, generation of data in a digital form, and it's sort of pooling in through the digital mission is what is a very critical need. Now unfortunately, even say the use of e-prescriptions is not something I would say in the country, not even 5% of the patients would be getting e-prescriptions. So we need to really work on actually starting the data in a digital form.
Very important points enunciated. I would like to welcome Professor Sumit Rai, Head of the Department of Microbiology from AIIMS Mangalagiri, and request her to come on the dais and join the panel discussion, please.
Please continue. We'll just join in. So they have a very phenomenal integrated stewardship laboratory for which they are being felicitated this evening. And since this is a session on the yoga of technology and tradition, I would like to put a bit of a tweaky question to Dr. Surabhi, that between an AI bot and your AIIMS Grand Round, what would be your I would say bias going towards it? Yeah.
So it's definitely going to be the AIIMS Grand Round, because I feel that patients, every patient is a case and a unique presentation in itself. And as Dr. Arun Kumar Goyal sir very rightly pointed out, that an AI of India, an AI of China, a protocol of India, a protocol of Europe, a protocol of a patient in US would be different. That is one. And secondly, also each patient is different. And sometimes we need to, really delineate as in the age, the kind of class, the kind of state of family, or what stage of life the patient is, what is his clinical presentation. So any treatment protocol may be advised, and I feel at the AIIMS Grand Round, our seniors and professors and colleagues are, just even at 9 p.m. in the night, at 11:30 and 5 a.m. in the morning, you get those, cracking diagnosis and the differential diagnosis, the predictive prognosis, and I'm grateful to our AIIMS community for the same. And it's doing wonders to my patients in Uttarakhand, especially as I'm serving the remote hinterland, where specialists are, very, very rare to find. So thank you so much.
I think we glide on to our last theme of this session, and we have a very eminent panel continuing that conversation. Is this streamlining, preventive, protocolized and integral health? Dr. Arun Kumar Goel talked a lot about the guidelines. Like in the lawyer's chamber, we see a lot of AIRs, All India reporters, but somehow the other, such kind of All India reporters, case studies are perhaps not bounded so very heavily in the doctor's chambers because they are very, very busy seeing 300 patients a day, something inhumane for that matter. And we have Dr. Hemlatha ma'am, who comes from the ICMR background, that somewhere or the other, even if we want to get ICMR guidelines, there is no agency to give us it in print. There are lovely PDFs, well decorated ones, even the latest NIA guideline on Bharat.
I share it.
Yeah, no, I'm just saying, if we can have a kind of a publishing system in place where there is an agency which can sell it off, because not everyone is so very conversant with the print sasta, ki PDF download karo, usko bhejo, wo aapke paas bheje. So in the old fashion, if the whole ecosystem can give to doctors the prints of things, because
Standard treatment guidelines is something we
they are so lovely, so powerful that as doctor, they have to be on the table of everyone. So moving on to this theme, and Dr. Hemlatha to talk about more, how to streamline preventive, protocolized and integral health. Ma'am's remarks on that, and then AIIMS Mangalagiri, because pathology is something which is the center stay of it all. They have integrated stewardship laboratory, well elaborate one. So over to Dr.
So with respect to non-communicable disease, I'm Dr. Hemlatha coming from ICMR National Institute of Nutrition, Hyderabad, and we impact policies a lot because we generate data, nationwide data on micronutrient composition of raw foods as well as cooked foods, and also we develop guidelines, and the latest one that we have developed and released is on 8th May, which is a very comprehensive one containing 17 guidelines. So coming to the preventive aspect, I'm sure most of you are aware that 80% of the diseases that are prevalent in India today can be prevented. 80% of diseases that are prevalent can be prevented. I'm very confident of that. Diabetes type 2 is escalating like epidemic, this thing. And along with diabetes type 2, cardiovascular diseases, especially hypertension, stroke and heart attacks are also increasing. And very uniquely in India, you see in younger population compared to the other parts of the world, much younger people are getting affected with this kind of non-communicable chronic disease, which used to be seen only after 50, after 60. Now even 30 plus, 40 plus people are getting type 2 diabetes, and these are all diet-driven, unhealthy dietary patterns. We just follow the West, and especially when European countries are so careful about diet, we just follow what the Americans do and grab a lot of unhealthy foods. So this guideline, and it is not just the urban cities, it is not just the urban areas, even in the rural areas. Even if you go to the remote village in a rural or tribal region, you can find biscuits. What is biscuit? It's just nothing but a highly processed product containing all refined flours and lots of sugar in it. Along with sugar, even the sweet biscuit will have some salt as well. And even a young baby of 6 months, 7 months is given a biscuit because it's easy for the mother to give the baby and pat the baby and make the child quiet. So we are not having a system where healthy foods are available, and also lack of awareness. People are not aware that it can be dangerous, not just for the adults, but for the young infants. Right from the age of 3 months, 4 months, they are exposed to highly processed food, and children are not getting enough vegetables and fruits, but they get lots of biscuits and chips. Biscuits and chips and cokes are available in every corner of India. Whereas healthy foods, they are expensive and not available, not affordable, available and accessible as well. So these 17 guidelines that we have generated have focused not just on sugar, but we have also developed a separate guideline dedicated totally to protein. There is so much hype about protein. Protein can be, we can have all the protein that is required from appropriate mixture of foods. Eat well, eat wholesome food, and have appropriate combination of cereals and pulses. You get what protein you require for your body. Whereas extracted, anything that is extracted, we should remember it is medicinal. So you can take them, but it is for a special condition and for a special duration. You can't take everyday protein powders in high quantities and for long periods. it can definitely take a toll on your health. People are not aware of these things. They just think protein means, yes, done. I'm going to be very healthy every day. You take 1 or 2 spoons of protein powders, that is especially after gym and all. It can affect your heart, it can affect your kidney, it can affect your bone, because amino acids, protein is nothing but amino acid. It generates a lot of acid. When acid is generated and you're not taking enough vegetables and fruits along with the amino acids, it can cause high acid, and the calcium in the bone will be leached out. So you will develop osteoporosis because of high amino acid consumptions. So these are all major issues, mostly because of lack of awareness, and also because of the food system that has changed a lot over the period of time. Availability, accessibility is poor, especially when coming to healthy foods. You see celebrities and you see highly qualified people, how careful they are and how healthy they are. You see most of them will be, gorging on lots of vegetables and fruits. That is not happening with middle class, higher middle class. Even the rich people who are not having awareness. And go to the rural, the same thing is happening. We eat lots of rice, whereas we eat burgers and pizzas. Both are again refined flours, refined ingredients. Lots of white rice, no vegetables, very little dal. So if time.
But ma'am,
Thank you so
I
much.
think when the celebrities don't get accounted, they will happily take money to advertise rubbish, and then they're not accountable for that. But also, ma'am, as a policy, ma'am, they will happily advertise for rubbish.
Celebrities, ma'am, stop
The
about
celebrities, they won't take
They
it
advertise
themselves.
about
There should be regulation for them.
But ma'am, I think at the policy level, and again Niti Aayog becomes important there, I think we have to be very careful about distinguishing semi-processed from ultra-processed foods. Because semi-processed foods are important. There's a glut of tomatoes, you can make tomato paste. There's a glut of onions at a particular time, you can make dried onions. Pineapple is rotting in the northeast, you can have products which will actually be financially and in terms of wastage very important, as opposed to ultra-processed foods which are garbage and which are also heavily advertised, and therefore they sell much more than the actual nutritional products which can be used financially viable and nutritionally viable. So as a policy, ma'am, perhaps we need to get the awareness that processed भी पुण्य भी हो सकता है, पाप भी हो सकता है.
We are not saying all processed food should be banned. Minimal processing is required for human consumption.
Yes, ma'am, what's happening is that process is becoming a bad word. So we need to be able to distinguish.
See, I have defined what is ultra processing. Fiber is depleted, micronutrients are reduced from 50 to 90%. So we have defined all that.
And it's very nice to see that you actually had the courage to say biscuits are garbage.
So in the treatment paradigm, when we say ahar, vihar, vichar, and then aushadhi. So this is, something I believe also that we've been trained at AIMS, and we have always been emphasized on food and diet, that a diet for a uric acid patient, a diet for a diabetic patient, a diet for a orthopedic postmenopausal woman. So where ahar is important. In fact, some of my colleagues at AIMS are also doing, research on ahar, food as medicine. Ahar hi aushadhi hai. So when we say that tej patta is anti-diabetic, when we say that so many food other elements, the spices, condiments only are beneficial if used in the right matra, ma'am. And similarly, when we say ahar hi aushadhi hai, so then we talk about the quantity of or portion size of a meal also. So wherein rice, South Indians consume a lot of rice, and if they take, I often observe, one katori is enough. They don't take a lot of sambar with it, to add to it. So this is good and healthy for the body. So this is something I am sure that the takeaways from this such a prolific, interesting discussion is going to be food for thought for all clinicians in NAS as well. So I would request Professor Sumit Rai sir to give his address and talk about his views on
the interface of technology as well as the prevention part of it all, because we have now got technology to measure what's happening in our body, imaging, blood testing, all that integrated stewardship laboratory, and perhaps That is the bottom line of preventive medicine as well in the modern medicine context.
So, first of all, thanks a lot to Dr. Survi and Rethink India for having me over here and bestowing an award for us. Thank you for that. Before I begin, just a brief introduction about myself. I am from a defense background. My father was in the Air Force. So I have changed 8 schools. When I got into medical college, I did my medicine from UCMS, did my MD from AMC, did my SRC from SGPGI, then back as faculty in UCMS, then got selected in UPSC, went to Subzering Hospital. From there I went to PGICH in Noida, and now south to AIIMS Mangalagiri. So I have seen the systems. So whether it's a central university system, whether a central government system, or a state autonomous body, or a center, whatever. So there are certain things that I've observed in all the different systems. And before I come on to the what we're talking about is like I'm into AMR because antimicrobial resistance is one of the main agenda in the G20 summit also. And in 2016, PM Modi, Honorable PM Modi, the first time in this Mann Ki Baat spoke about AMR, what is antimicrobial resistance and how is going to affect the health. And as speculated by Lancet also, by 2050, 10 million people will die every year because of the AMR, antimicrobial resistance. And because it's something that you take an antihypertensive, it's going to affect you. But if you take an antibiotic, it's going to affect the entire community, the entire environment, hospitals, whether it's animals, the entire